Want to welcome everyone here to this is the first of our panels. So on social media and wearables, we've got a great panel ahead of us. Why don't we start by having Thomas introduce himself?
Good morning. My name is Thomas Lee from Simpler, one of the co-founders of the Healthcare Hashtag Project.
Next, Barrett.
Hi, I'm Barrett Larson. I'm actually a resident here in the Department of Anesthesiology, and I'm also the co-founder of Leaf Healthcare.
And Aaron.
I'm Aaron Gray. I'm a family medicine physician and sports medicine physician at the University of Missouri.
And then Gonzalo.
I'm Gonzalo Bacigalupe. I'm a family therapist and a public health researcher, and I'm a professor at the University of Massachusetts, Boston.
Excellent. All right, so we're going to get started. Thomas is going to go first, so let's everyone welcome Thomas.
Good morning. How many patients are on the majority of healthcare conferences' top 100 social media influencers? This is a typical profile of the top 100 influencers at a healthcare conference. And the red nodes indicate patients, the black, everybody else. That's right. One out of 100. The majority of healthcare conferences around the globe have a single patient represented on their top 100 social media influencer list as measured by mentions on Twitter. This research project that I'm going to share with you this morning is a collaborative effort between myself, Audun Utengen, my partner at Simpler, Britt Johnson, and Nick Dawson. And it was, these last few years, there's been a lot of anecdotal data that has really shown us this growing engagement by patients at healthcare conferences. And this is something that has caught our eye over these last few years, and we wanted to dive into it a little bit more and see how the patients are influencing these conferences, what the impact is on the healthcare conference. We started out by taking a look at 1,086 conferences from around the globe that Simpler was tracking in 2013. And out of those conferences, there were over 1 million tweets. I mean, that's an amazing number by itself. But what's maybe equally or more amazing is how we've come to democratize the information that used to be hidden in those conferences. Because with social media, we're now able to share that information in real time around the globe, and it makes a much wider impact than it could have possibly done otherwise. So with this study, we started with these 1,086 conferences, but we knew that we needed to scale this down to some more manageable level. So we decided to only look at those that had more than 1,000 tweets coming from the conference. And that left us with a qualifying list of 217 conferences. And from that, we did a completely randomized sampling of 100 conferences. And it was those 100 that we were going to dive into and take a closer look at. So one of the first things we had to do was decide how are we going to measure who's influential. And we decided to focus on the number of mentions on Twitter during the conference. We could have taken the number of tweets, but just because somebody's a prolific tweeter does not necessarily mean that they're influential. And we could have taken a look at impressions. Impressions is, that's an interesting number, but we knew that in this case, it would be too easy for one or two large companies with huge Twitter followings to really skew the data. So we decided to stick with number of mentions on Twitter. The next was identifying who the patients are. And this was probably the most research-intensive part, because what we did is after we identified those 100 influencers times 100 conferences, we're looking at almost 10,000 user profiles, and we extracted those Twitter profiles and strictly looked at the bio information, the Twitter bio information. And what we were looking for were for people who had self-identified, or self-disclosed as patients. And we did searches for words like cancer survivor or e-patient and a variety of other diagnoses, health condition terms, and so on, in order to be able to identify who these people were. So how many patients did we find? 198 unique patients. And of those 198 unique patients, they occupied 279 influencer spots across these 100 conferences we were studying, which means that some patients attend or participate in more than one conference per year, just like some doctors do. And this is a trend that we've seen evidence of. More and more e-patients wishing to attend multiple conferences over the course of a year so that they can share their stories, their thoughts and ideas about how to make healthcare better. The next thing is if we look at this and we say, well, how many conferences had at least one patient as a top influencer? 65%, more than half. Well, that sounds good, but it's a misleading number. To put it into better perspective, if we look at what the median number is of patients at these conferences, and we're back at that number one patient. And I dwell on that because this is not something that we were seeking. This is not part of the study per se, what we were looking for, but we uncovered it along the way. And I think that it shows that there's tremendous room for improvement, if nothing else. If we were to take a look at all of these 100 conferences that we were going into and diving into and looking at for this study, and to graph them, if you look at this, graphed by the frequency of having patients or the number of patients in participation at the conference, on the left we assume that those are the industry leaders, the tier 1 conferences that are leading the way. And we assume that those on the left, or excuse me, the right, are the tier 2 conferences, the ones that are continually lagging behind the emerging trends. And I know there's not enough room on this graph to be able to show you, what these conferences were, their names and such. But if you'll allow me just to highlight the one on the far left, anybody care to guess what that conference is? That's right. That's right. You're breathing rare air today. So what does patient inclusion do for conferences? Our hypothesis was that patient-inclusive conferences will perform better on social media than non-inclusive conferences. Pretty simple. And there's lots of anecdotal data that would support that. And it's been my own personal observation in attending conferences that those that have patients participating can really take a conference to another level. But we really wanted to see if we could get beyond these anecdotal aspects of it. So, in order to find the evidence that we were looking for, we took these two groups that we had come up with. We basically took those conferences that had more patients and those conferences that had less patients, or in some cases, no patients. And then we conducted a t-test just to make sure that these were statistically different groups, and they were. Like I say, that's what we wanted. And then we wanted to compare or decide what we were going to compare them on, what the metrics would be. And so we decided to focus on the number of tweets and also the number of Twitter participants. And this is what we found. Patient-inclusive conferences far outperformed having a larger conversation and more tweets coming from the conference. We also found that the average number of participants, patient-inclusive conferences, again, far outperformed, reaching a wider audience and making a much larger impact. So, we are able to say that patient-inclusive conferences clearly perform better with a larger conversation and wider social impact. The next thing we wanted to do is to see if we could predict that more patients would result in improved performance metrics. And so to do this, we did a multiple regression analysis to see how the increase of patients could explain the improved performance. And we found that the model supported our hypothesis. and that it was statistically significant, although with a somewhat low explanation power. But to answer that question, could we predict? In layman's terms, yes. We could say that more patients will result in greater social media participation on the metrics that we studied. So, there you have it. However, there's one question that is probably still left to be answered, and that's obviously why. Why do patient-inclusive conferences perform better on social media? And quite frankly, that's beyond the scope of what our study was. But I can offer you an opinion. I'm never short on opinions. We can look at healthcare as being made up of people. And in a maybe somewhat simplistic way, we can organize these people into three groups. We've got the patients, we've got the providers, and we've got third parties who are helping to facilitate communication and dealings between the patient and provider. And when all three groups have got adequate representation in conversations or in conferences, we're presented with a much more clear, complete, and larger picture of what the world of healthcare is. And when we're presented with that larger view, strong conversations emerge. And the performance metrics that we measured in this study will excel. Thank you.
All right, thank you, Thomas. So we will now start taking questions. We have, I believe, 3 or 4 microphones up here for you guys to come up. Who wants to be the first brave one to ask a question? We also have on Twitter, I'm tracking the MedX hashtag. You guys are hopefully going to ask some questions on Twitter. I've been documenting some of them. So, does anyone want to come up and ask a question? If not, I'll start it off. Okay, so Thomas, my question, so what are the implications of this for the patient, for the provider, and even for policymakers? How can we translate this into, it sounds like, we're all here and we agree that having patients involved in the conference is definitely a good thing. It benefits all of us. So what are the implications for each of those areas, whether patients, providers?
Sure. I think, first of all, I go back to that number 1. We can see this impact. And, of course, this conference is a prime example where we have this nice, beautiful mix of stakeholders. And we can see how energized this is and how much information is being shared and being not just shared here, but across social media. And, but the majority of conferences only have one patient in that influential spot. So I think that just does show, like I said, there's this really tremendous opportunity for improvement there. I would think that conference organizers would be very interested in this, and I would think also that it should encourage patients to go to these conferences, to seek getting involved. We have a tremendous example here, and I think that this is responsibilities on both sides. Patients to get more involved, conference organizers to be more open to inviting patients and encouraging patients to get involved. It furthers the discussion, and again, it goes global. It doesn't just stay locked up in the conference.
How can the public get more engaged? Based on these findings, it's important that we have more patients. So what's the next step in order to get more patients involved? Because we did see that skew, and that's a problem, it sounds like.
Sure. I think everybody has some responsibilities there. And I think that within the circles that we're in this room right now, people can understand this. They can understand the impact. People who are not involved in social media aren't nearly as aware. And kind of bridging the gap between those of us who are in the online space and those who are not yet in that space is a difficult one that mainstream media has not yet picked up on. And I think that's a shame. I think that if there was more attention from outside these circles looking in, I think that would open up some eyes and people would discover there's a tremendous amount of resources here.
We'll take a question from the audience now.
Wow, that was loud. Hi.
Hi.
One thing I found is that there is a very definite attitude among the conference organizers and even in the medical community that patients are a distraction at a conference. How do we get past that?
I think that this study goes to show that the conference organizer, if their interest is in communicating the thoughts and ideas coming out of their conference with a larger audience, I think that this explains that this is in fact a good way to do that. You could see that it wasn't just better performance. I underline the word substantial. It was the difference was really substantial. And I think that they should take note of that if they want to spread the word.
Another question back there.
Hi, I'm a social media manager at a hospital, and something that I've found to be very effective is outside of conferences, just in everyday conversation, sharing tweets, Facebook posts from patients with the providers who are actually mentioned. So I'm wondering, with all the data you're collecting, how are you then sharing that with hospitals, healthcare organizations? It seems like there's a lot of cool stuff there, but how is that actually getting to professionals who might not be using social media, but who once they see it, then kind of understand a little bit more about the conversation that's happening?
Sure. On our website at simpler.com, there's a section that's called the Healthcare Hashtag Project. And if you're not familiar with it, I would encourage you to take a look at that. What it does is, and it's been going on for 4 years now, where we've been capturing, focused anyway, on hashtags that are relevant to the healthcare field. And we're monitoring, capturing all the tweets, we're providing analytics, we're introducing you to who the most influential parties are in these conversations, how active they are. We're introducing you to other hashtags that are also sharing the same subject matter. So it's a great place to go and explore and see the amount of activity that's taking place, to see who's involved and how you can get involved. So I know that's part of our project, but I would really encourage you. I think it's a great starting place.
There are some conferences that are inviting and providing scholarships for patient advocates, two of them being ASCO, Clinical Oncology, and the American Association of Cancer Research. However, they seem to define patient advocates as being associated with a nonprofit. And there's a very large contingent of us that are independent. They're not with any particular nonprofit. So I'm wondering what we can do as a community of bloggers and people on Twitter to help get the larger organizations to realize that there's a larger contingent there. I attended ASCO as an independent consultant and discovered that there was a whole group of activities that patient advocates were invited to that the independent ones didn't get invited to because somehow we weren't on the list since we weren't with nonprofits.
Yeah. The patient voice collectively, individually sometimes is difficult, but I think collectively your voice is very powerful. And it's becoming more powerful. And I think that as a group, if you were to lobby the various conferences, large conferences, to get things going there where larger impacts can be made, I would really encourage you to do that. It's a struggle, I realize that, and this is all a process. But we've seen more and more patient inclusion. We just need to speed it up. And like I said, there's so much room for improvement. We're hoping that by demonstrating this via a formal research study, that we're able to open up some eyes and help people to understand that this is in the conference's best interest, and it's in the best interest of the outcome for everybody.
Will that data be available to us?
We're hoping to write up and publish this study in the very near future. So yes, that would be available. And the abstract is on the MedX website.
Okay, we have time for one more question.
Thank you for doing the study. I think it's really important. I'm really interested in the panel's views on how you actually get funding to get patients there. So I run a conference, or run quite a lot of conferences in Australia. We are a non-profit, and so if I have patients there, we pay for it ourselves. I cannot convince commercial enterprises to provide scholarships. I've tried so hard for years. Your data might actually help, but if you've got other ideas, because they just want to see a return on their investment, and they don't think they're going to get that from supporting a patient to attend a conference. So love to hear some ideas on that. Thank you.
Well, for starters, I think that it's good PR for their brand. And if they're serious themselves about inserting their company into the online space, and I think they should be, I think that's some tremendous goodwill that they could offer. And I think they'll get that recognition, and that in itself is worth something.
All right. Thank you, Thomas.
Thank you.
So next, let's welcome Barrett. Barrett's going to talk to us about wearable patient sensors for ulcer prevention.
All right. Good morning. The story I'm going to share with you today starts about 6 years ago. I was in medical school and on a clinical rotation at a local county hospital, where I had the opportunity to help care for a woman that had unfortunately sustained a severe burn injury. From the beginning, it was unclear if she was going to live. She was intubated, transfused, resuscitated, taken to the operating room for various procedures, but over the course of the next several weeks, she made an incredible recovery, and her life was saved by an amazing team of doctors and nurses. However, when I went to follow up on her months later, I learned that an infected pressure ulcer had caused a severe bloodstream infection, and she was now once again fighting for her life. I couldn't believe that a pressure ulcer, a bed sore, was capable of putting someone's life in danger. I was immediately inspired to learn more about this problem. It turns out that there is a pressure ulcer epidemic in this country and around the world. In fact, in the United States, 1 out of every 30 hospitalized patients will develop a pressure ulcer. This is a problem that impacts well over 1 million patients every year. Given the magnitude of the pressure ulcer epidemic, I teamed up with a fellow medical student, Daniel Shen, and together we set out to see if there was anything we could do to help. Our first step was to fundamentally understand what causes pressure ulcers. As the name suggests, pressure is ultimately responsible for the formation of pressure ulcers. When patients lie in bed for long periods of time and remain in one position, the sustained pressure impairs capillary blood flow, which leads to tissues being starved of oxygen and vital nutrients. The result is tissue damage, and this damage can be so severe that skin and underlying fat and muscle can actually die. Pressure ulcers initially start as just an area of redness, but if left untreated, they can evolve into full-thickness wounds that extend all the way down to the bone. Normally, when we lie in bed at night, we toss and turn, shift our weight, and do subtle micro movements to help prevent pressure from building up. However, patients that are sick, elderly, medicated, delirious, they don't necessarily perform these normal movements, and as a result, they're at risk for developing pressure ulcers. Pressure ulcers are not only unsightly, they're also very expensive to treat, and they pose a huge burden to our healthcare system. And because pressure ulcers are considered preventable, these treatment costs are not reimbursable. And this is just the direct cost. To put that cost into perspective, each year we spend more healthcare dollars treating pressure ulcers than we do treating influenza. Pressure ulcers also negatively impact a hospital's quality metrics, which is becoming increasingly important in this era of pay for performance. Pressure ulcers also open up institutions to potential litigation. Again, since pressure ulcers are largely considered preventable, they can sometimes be viewed as a sign of caregiver negligence. And beyond the financial implications, pressure ulcers have a significant impact on a patient's quality of life. So how do we prevent pressure ulcers? Because some patients are not able to turn on their own, they are completely dependent on their nursing care. About 160 years ago, the importance of patient turning was first popularized by Florence Nightingale during the Crimean War. She developed the concept of turning protocols, where wounded soldiers were turned and repositioned every 2 hours around the clock. Patient turning has since become a fundamental practice that is now ingrained into the fabric of nursing care. Even to this day, there is a consensus amongst nurses and physicians that frequent and regular turning is critically important to pressure ulcer prevention. This has been the standard of care for pressure ulcer prevention for almost 2 centuries. Many hospitals use a turn clock like this one to help coordinate turning efforts. Patients are put onto a specific side of their body during each 2-hour time block throughout the day. However, despite the simplicity of this approach, it's been shown that compliance with turning protocols is poor, and as a result, pressure ulcer rates have remained high. Given the importance of turning, a number of studies have examined compliance rates with our traditional turning protocols. In 2001, a very large multi-center study was conducted to determine how closely our standard 2-hour turning protocol was being followed on a national level in high-risk patients. The authors concluded that compliance was only 66%. In a separate study involving ICU patients who were prospectively monitored, it was found that many of these high-risk patients were simply not being turned. A staggering 1 in 4 patients remained in the exact same position for over 8 hours, putting them at a significant risk for developing pressure ulcers. So why are so many patients falling through the cracks? Maintaining compliance with the turning schedule is not easy, and researchers have identified a number of problems with traditional turning protocols. First and foremost, it's difficult or impossible for a nurse to continuously monitor each patient's position and movements. The turn clock is unfortunately not able to alert providers if they turn into an undesirable position. For example, a nurse may go and turn a patient, but the patient can potentially just roll back onto a recently pressurized area without anyone really knowing. Also, for patients that have existing pressure ulcers, it's highly desirable to keep them off of those areas at all times. But again, the turn clock cannot alert providers if they turn onto a pressure ulcer. Second, the turn record documentation is often incomplete, or it inadequately reflects a patient's true position history. When care is being transferred between providers, having an accurate and reliable turn record helps ensure that patients are turned in the best way possible. For example, if the position history indicates that a patient has been lying predominantly on their backside or their right side, with that information, a nurse may decide to turn the patient onto their left side in order to optimize the overall pressure distribution for the patient. Without accurate documentation, that type of position optimization is just not possible. And finally, in the busy hospital setting, the turn clock has proven to be an ineffective alerting and reminder system. In this age of shrinking nurse-to-patient ratios where resources are stretched and nurses are task saturated, it's unfortunately not surprising that turns can get missed. So given the limitations of the current prevention methods, Danny and I decided to develop a technology solution that would help ensure that no patient slips through the cracks. In order to improve nursing efficiency and patient care, we developed the Leaf patient monitoring system. This wireless, single-use, disposable sensor is able to continuously track and monitor the movements and orientations of hospitalized patients. The device is FDA cleared and is designed to provide nursing staff with a better way to monitor, coordinate, optimize, and customize turning schedules for large groups of patients. At the core of the system is our patient sensor, which is a small, lightweight, wireless device that continuously monitors every patient's movement and orientation. Data from each sensor is communicated to a proprietary mesh network of relay antennas. These antennas are distributed throughout a monitoring environment, and they ultimately transfer data to a central server. From the server, data is aggregated and then can be displayed on any web-enabled device, such as tablets, computers, or even cell phones. From the monitoring station, nurses and other staff can easily identify patients that are in need of assisted turns. Any patient in need of assistance can easily be recognized by a simple green, yellow, and red color scheme. The system also automatically recognizes and documents any adequate patient self-turns so that nurses don't need to turn patients that are turning on their own. All of the desired turning parameters, such as turning period, turning angle, and decompression time, can be individually customized for each patient to allow for personalized care plans. In order to assess how this system impacts compliance with patient turning protocols, an empirical study with an interrupted time series design was performed. The study was conducted in a 39-bed acute care medical unit, and 138 patients were divided into control and intervention groups, and our sensor was used to objectively monitor the turning compliance in each patient. In the control group, our sensor was applied to patients, but the sensor data was not provided to nursing staff. Nurses continued to coordinate turning schedules in the typical fashion using their standard reminders and documentation. 75 patients were analyzed in the control group, and over 4,000 hours of continuous position data was collected. Once the baseline compliance had been established, we then turned on our monitoring station, our user interface at monitoring stations, at which point the Leaf system began coordinating and optimizing turning efforts. We analyzed 63 patients in the intervention group, and over 3,500 hours of continuous position data was recorded. Our primary endpoint was compliance with the hospital's standard 2-hour turning protocol. In the control group, the average compliance was 64%. Following implementation of the Leaf system, the compliance increased to 98%. The effect was even more dramatic in patients in isolation rooms who are typically less visible to nursing staff. In these patients, the average baseline compliance was 48%. After implementing the Leaf system, the compliance increased to 99%. We also analyzed compliance by time of day and by nursing shift. In this graph, on the x-axis is the time of day and the y-axis is the compliance rate. As you can see in the control group, there was a significant amount of variability in compliance depending on the time of day. After implementing the Leaf system, the degree of cyclical variation decreased and the compliance was higher at all hours of the day. The system allowed staff to deliver a standard, high-quality pressure ulcer prevention program to each patient. Historically, there have been many attempts made to improve compliance with patient turning protocols, but nothing has really proved to be effective and sustainable. Bev Jackish, a wound care nurse with decades of experience, feels that this is the first system to really work. Traditionally, turning protocols have taken a cookie-cutter, one-size-fits-all approach. However, patient turning is a therapeutic intervention, and as such, it should ideally be customized to the individual patient. Just as you wouldn't give every patient the same medication at the same dose at the same time of day, turning should also be customized based on patient-specific factors. With improved software analytics and artificial intelligence, we now have the ability to create a more data-centric approach to patient care. With integration into electronic medical record, we now have the ability to automatically assign patients to the optimal turning schedules based on hospital protocols and current research. And the system has the ability to deliver highly personalized care that is sensitive to patient-specific factors and even environmental factors, such as the type of bed the patient's on, the time of day, or even caregiver staffing ratios. Position monitoring technology represents an evolution in an age-old nursing practice and allows nurses to deliver a higher quality of care in an easier and more efficient manner. There are a number of other applications for this technology, and our goal is to broadly help prevent the complications associated with immobility and improve the healthcare experience for patients and their providers. In the future, we're exploring using our system as an ambulation monitor to help doctors and nurses monitor a patient's compliance with prescribed ambulation protocols. It's been shown that frequent and early ambulation during a hospitalization helps prevent complications and reduces the length of stay. Our system can also function as a fall detector and alert staff if a patient has fallen. Like pressure ulcers, falls are considered never events, and as such, they negatively impact a hospital's performance metrics. Not only can we alert staff that a patient has fallen, our system has the ability to track a patient's location so that we can quickly find them and treat them. For patients that are supposed to remain in bed because they are a fall risk, our system has the ability to alert staff if a patient attempts to leave their bed or their room. And finally, our system has the ability to continuously monitor a patient's heart rate and respiratory rate, which can detect the first signs of patient deterioration. Over the years, the market for wearable technology has begun to explode. Wearables have enabled consumers to track virtually every aspect of their daily lives, from their activity level, their stress level, vital signs, even their mood. Consumers are clearly very interested in the concept of the quantified self. I believe there is a place for wearables in the patient care environment, and that this technology can be used to help improve diagnostic capabilities and therapeutic outcomes. As I think back to that patient experience I had as a medical student, I only wish that position and orientation monitoring systems had been more readily available then. I'm hopeful that one day this type of technology will be able to, all patients will be able to benefit from this type of technology, and that we'll no longer see the horrible complications associated with patient immobility. Thanks.
Thank you, Barrett. We'll now take some questions on the floor.
Thank you, Barrett. I have a question back here.
Oh.
Do patient family members have access to the data as well? And if not, what would it take to do that if I have a loved one in the hospital that I also want to monitor myself?
Yeah, that's a great question. That's something we've been exploring as well. The whole patient and family motivation piece is huge. With this data, we can potentially provide it directly to patients and directly to patient family members to allow them to really start to take part in their care. For example, if we're able to provide this data to a patient's family members, they can take a little bit of ownership over the turning potentially. They can help encourage their family member, their loved one, to get up and out of bed, walk around. So that's definitely something that we're potentially looking to do in the future.
So just a note for those of you asking questions on Twitter, if you can tweet at the presenter or at me so that I can be able to figure out which of the tweets are related to this session easily. Yes, Barrett?
Oh, it's Barrett_Larson.
Barrett_Larson. And mine is Sean Young, PhD. We'll take a question from the floor.
Yeah, I mean, you were specifically talking about bed sores and sensors to prevent that. But my brother had neurosurgery last year. He had a benign meningioma, and post-surge, he said he felt like a rodeo clown because he had like all this stuff all over him. He was ambulatory, but getting out of bed and getting into the bathroom, it was definitely like sort of a juggler meets a rodeo clown. I'm wondering if you are looking at doing some monitoring tech, wearable monitoring tech, because he and I talked about this afterwards. Like, why can't this at least be a vest, if not like stuff that you just wear instead of this panoply of external devices? And it's because it's nuts. You're supposed to get out of bed, but meanwhile, getting out of bed requires an entire committee. And that doesn't seem effective.
Yeah, indeed, that's a big problem. Oftentimes patients, especially post-surgical patients, ICU patients, they're literally tethered to their bed by any number of wires, EKGs, various different lines, IVs, and so forth. It does make it difficult for patients to get up and out of bed. It's not a problem we're addressing right now. But I think globally as a group, as an innovation community, we should start thinking of ways of developing more just wireless technology in general to monitor.
And anybody around here who has DoD contracts with some of that wearable tech for warfighters, I think there's another opportunity here.
Great. We have time for one more question.
Thank you very much. I'm involved with ALS. Have you looked at anything for the home care kind of environment? People with ALS are just terrible victims of pressure sores.
Yeah.
Anything for the patient who's not bedridden but in a power chair all day, that kind of thing? So.
Yeah, absolutely. We certainly are exploring moving into long-term care facilities, potentially home care. Right now, our focus is more on the acute care medical setting, but we certainly don't want to limit ourselves just to that market. Also, you mentioned power chairs, wheelchairs, things like that. One of the benefits of our technology is it does monitor the surface pressure distribution and the change in position when patients are on any surface, not just their bed. So if they're sitting in a couch, in a chair, in a wheelchair, what have you, it can still help coordinate turning schedules and provide reminders if a patient needs to be turned or repositioned.
All right. Thanks again, Barrett.
Sure.
So our third speaker will be Aaron. Aaron is a sports medicine physician who will be talking about a Kinect screening tool.
Thanks. Yeah, my name's thank you. My name's Aaron Gray. I'm a family physician and a sports medicine physician at the University of Missouri. My slides will appear right now. At Mizzou Sports Doc, if you want to tweet me any questions or continue this discussion afterwards. So I'm going to talk about preventing ACL tears. And so the ACL is the anterior cruciate ligament. It's one of the main ligaments in the knee that stabilizes the knee. Preventing these tears in female athletes using video game technology. And so we heard earlier about the epidemic of bed sores. I'm going to tell you about another epidemic. And so there is also an epidemic of female athletes who have suffered ACL tears. So who here knows a female athlete who has torn their ACL? Quite a few hands. And so unfortunately, this is a very common picture on many couches and in many basketball teams, is that you see athletes like this. So what are the stats behind this epidemic? So female athletes have a 4 to 6 times increased risk of tearing their ACL than their male counterparts for the same sport. And then also we have a lot more girls that are playing sport, and this is what we want. So since Title IX was passed a little over 40 years ago, we have 10 times the number of female athletes that are playing sports in high school and 5 times the number that are playing sports in college. So with this increased rate of participation and this increased risk of injury, we're seeing a lot more. And many people don't know that, but the peak age of ACL tears is actually 16 years old. So this is something that happens very early in life, and 50% of people who tear their ACL 10 to 15 years later have x-ray evidence of arthritis in their knee. So half of people in 10 or 15 years are going to start having some arthritis. So we're starting to see women in their 30s who tore their ACL when they were teenagers who are having early arthritis. This is also not something that's cheap. So this is some figures, at least $25,000. When I talk to some surgeons, they're like, oh, it's much higher than that when you look at the global cost. So this market could be even up to $2 billion in the year when you look at all ACL tears. Some data from 2001 is that there were almost 40,000 female athletes that had ACL tears in the U.S., and so a cost of $650 million and probably even up to $1 billion. And so this is kind of one example. This is the Mizzou soccer team. So a great study that was done a few years ago shows that 1 in 20 female athletes who play basketball or soccer year-round will tear their ACL every single year. 5% of female athletes every single year, if they're playing year-round, will tear their ACL. So you can imagine year 1, one gone. Year 2, another. Year 3, and year 4. So if you look at almost any high school female sports team, as far as soccer or basketball, you'll see somebody sitting at the end of the bench who has a knee brace on, or somebody who's out there playing with a scar in their knee from where they had their ACL reconstructed. So why are female athletes at increased risk? There's been a lot of research. People have looked at hormones. Maybe there's a little bit of correlation, but not really something that you can change. They've looked at some of the specific anatomy and bone structure. Again, you really can't change that. So we've got a lot more into looking at neuromuscular changes, and these are actually things that we can do something about and prevent. So it's interesting, when kids are, before puberty, boys and girls jump and move pretty much the same. But after puberty, girls start to move a little bit different. And so Tim Hewitt at University of Cincinnati and at Ohio State has done some great research looking at some of these factors. And so these are some of the key factors. So one of the things is that girls often, when they jump and land, they'll rely on their ligaments to stabilize their knee rather than their muscles. One of the ways they do that is so they fire their quads. And so if you fire your quad muscles in the front, it makes you stiffen your legs. Well, if you stiffen your legs, you can't absorb the impact. And so you'll see often teenage boys will land a lot more kind of softer and a lot more bend in their knees because they're firing their hamstrings, and that's a lot more protective. Also, girls often end up being single leg dominant. So if they jump and land, they almost always are landing on one foot. Well, if you land on one foot, that foot's getting all the force compared to landing on 2 feet. Also, there's a lot of core muscle weakness, and this is a big reason we encourage these girls to do Pilates and yoga. So if your core muscles are weak, it's kind of easier for you to be kind of turned over. And so if you go up for a rebound and you get kind of jostled on the side, and then you kind of turn to the side and you land on that one leg, you can just imagine how that knee can give way. And so this was a great study that was done by Hewitt in 2005. So he took 205 female high school athletes in some high-risk sports and measured them with a Vicon motion capture system. So this is the same type of a system where you put reflective dots on somebody. You might have seen these for like video games or sci-fi movies. They can see people. Same technology. And so had these girls jump or drop off of a foot-tall box onto the ground and then jump up as high as they could like they were reaching for a basketball rebound. And they measured a lot of angles on these athletes. Well, 9 of the girls suffered ACL tears of these 205. And so the group that suffered ACL tears, their knees, when they first touch the ground, we call it knee valgus, or when the knees cave in like this. And so if you ever watch a junior high girls basketball game, a lot of times you see everybody jumping and landing like this over and over. And so when those knees cave in, the girls that tore their ACLs, their knees caved in 8.5 degrees more than the rest of the girls. They also landed much more stiff, so they had about 10 degrees less of bend in their knees when they landed. So they landed stiff and with their knees together. And this is just a graph that shows the X's are the girls that tore their ACLs. And so if you look at the graph on the right of the screen there, that's that angle when they initially tore it. And so the thought by looking at this is, what if we could target those girls that are at high risk and identify them early? Are there potentially some interventions that can be done? And so my journey with this and looking at the Kinect is I was a sports medicine fellow at UCLA about 3 or 4 years ago, and I convinced my wife that we could plop down, even though we were spending a lot of money on rent and making very little, that we could spend some money to get an Xbox with the Kinect. So I got the Xbox, and I was playing some games, and as I was playing the games, if you're not familiar with the Xbox, whenever you move, it senses your joints at like 20 different joint centers. And so whenever you move, you can like move your knees in and it reads your knees. You can scratch your head, you can pull up your pants, and the sensor senses all that. And as you move, your character moves. I'm like, what if we could use this for medicine? What if this could be translated? I had just read some of that previous research. And so also I started looking at what are the differences in these two systems, possibly this expensive system versus something much less. Well, the Kinect is 1/1000th of the cost of the Vicon. So, that works. The Vicon is only in the lab. The Kinect is portable. Vicon takes lots of markers. It takes lots of time to do that. The Kinect is markerless. And also we can get instant measures of angles with that. So we start to see some big benefits if we could translate this. So now at the University of Missouri, so I connected with computer science and computer engineering department, and we tested this. So we got a Kinect, and we got the Vicon system. We hooked up about 15 people, had them jump multiple times, doing the exact same jump that had been proven before. And we had about 80 kind of successful jumps. 2 people we had to exclude because of technical problems. This is a look at one of our PhD students that was doing this in the lab. If you're a PhD student out there, you're always going to be the test dummy for these on the slides. And so this is kind of a look at our results. So the pluses, the red pluses, is the Vicon data from the expensive sensor, and then the blue X's are the Kinect. And so that is every single jump that was done. And so we showed that the jumps, there was a standard deviation of about 1.7 degrees. And so if you have an athlete jump 3 times, which would be our test, that then you're within 95% confidence interval of being within 2 degrees, which is good enough for a screening test. It also looked at something called the intra-class correlation coefficient, and so values above 0.75 show excellent correlation, and these values were 0.89. So we showed that this technology is accurate enough that it corresponds. And so then we kind of set on to develop and to automate this and start to develop something that we actually could take out to gyms, to sports physicals, and start testing high school girls. And so we kind of call this ACL Gold. And so this is a look at some of the software that's been developed. And so when the athlete stands up on the box, that we kind of read those joints. And then as the athlete drops down and then jumps up as high as they can, then we get some immediate angles right afterwards. And so we look at that knee valgus, or how much those knees cave together. We also look at the distance between the knees and between the ankles. That also gives us a measure. And then once we can complete those, and we've now built out a website that these can be uploaded, and so we're going to start studying high school girls and make sure that our technology corresponds to this previous technology. And so okay, that's great. You know, if you can screen for something, but you can't do anything about it, then that doesn't do anybody good. So what can we do whenever we screen these athletes and show that they're high risk? So ACL injury prevention programs work. There is a lot of excellent evidence in the literature that these programs can decrease ACL injuries in these female athletes from 30 up to 80%. And so if you can decrease it by 80%, then you can get down to the same risk as their male counterparts, and that would be a goal. And so it incorporates a lot of balance training, a lot of kind of like biofeedback as far as landing kind of softly and with your knees straight ahead, a lot of core strengthening. And then also we want feedback on the technique of the drills to make sure people are doing the drills correctly. So these are look of some of the different types of drills that we do. We can have girls jump and land. This really fires the hamstrings a lot. We also do a lot of single leg balance exercises where they're hopping around and on top of a Bosu ball for core stability. Also laying on their side, doing some clamshells or side leg lifts. And so if anybody, the female in the purple pants there, if anybody's ever tried that before, I give you applause. Very, very hard to do that. The problem is non-compliance. And so, you know, these are our target population is teenage female athletes. They're busy. These exercises might be seen as boring. Maybe if they don't know anybody that's torn their ACL, they see, you know, athletes never think about an injury until it's happened to themselves or someone close to them. So non-compliance is a huge problem. So what can we do to make this fun? So another phase of our project is when this was available, a lot of my teenage female patients I saw, what were they doing before I got in the room? They were playing Flappy Birds. And so what if we could make games that kind of appeal or things that are similar to games that our target population likes? So we came up with Happy Tiger. All right, I wanted to use Flappy Tiger, and our intellectual property people are like, no, you can't really do that. So Happy Tiger. At Mizzou, we also have lots of columns. It's one of our kind of landmarks. And so you can see here, we're going to have people do side leg lifts and propel the tiger to go through the columns. Or they could do really hard if they get good, and we could build certain levels. So our kind of prototype could do something like that. And so this is what we've worked on in 2 or 3 months. So we have some developers, computer science students who've used Unity to kind of build out our prototype game for this. And so you can see the tiger there, and you can see the picture in the bottom right-hand corner of someone who's doing this. And this is something that we want to build out even further, just as kind of a proof of concept that this can be done. And so what if, these games on the Kinect could be, instead of just, dancing games where it shows that you have really good rhythm, what if we could actually target interventions for specific muscle groups that are shown to prevent injuries? This wasn't possible without a multidisciplinary group. It's one of the strengths, I think, of Stanford. There's some universities where the med school and the undergrad campus are separate. At Mizzou, we're very fortunate to have those together, but I think that is really a key for innovation, to have people close by. And a couple of our students are out here and really appreciate their help with this. So our next steps, this fall we plan to go out and screen about 400 high school girls who play basketball and softball, and then follow them for a year. And eventually we want to look at more proven things in the literature as far as proven movements or proven movement patterns, and we want to build out more screening tools that can help assess those. And so that's pretty much it. Thanks a lot.
We'll take some questions now.
I got one. It's just going to take me a minute to get there. So, yeah, thank you. I'm a 3-time ACL patient. It's the first time I've ever been identified as a patient in medicine. We don't often talk sports med. And the current owner of a fractured femur. Oh. Two questions. One is, you focused on a cohort of women, and then very quickly it sounded like maybe your work could be applied across genders. I'm curious to hear you talk about that. And then secondly, what's your thoughts on preventing re-injury? The data I've seen suggests that the #1 indicator of a second tear or a third tear is having had the first tear. And do you have any thoughts about using this in rehab from somebody who's had a rebuild?
Yes, no, great question. Yes, as far as the gender thing, so one of the reasons that we kind of targeted it to female athletes is because the data shows more that those faulty movement patterns that they have are more easily reversed, but you definitely find some males that will have kind of poor mechanics as far as movement. And as far as the re-injury, that's kind of another slide set, but is a great kind of, I see it as a market area potential. So orthopedic surgeons, whenever they return people to sport, kind of historically it was, let's look at the calendar. Yeah, you're about 9 months. Yeah, maybe you can go back. Or let's look at some strength tests on a machine. Okay, your strength is good. But just because your strength is good or you've been a certain time period out from your surgery doesn't mean that you're healthy to go back. And so we really see this as a tool that could be used with further development as a return to sport. And so making sure that your movement pattern, so your injured leg is just as good as your other leg. And if you started off with bad movement patterns in both legs, that we've improved those. So a return to sport is definitely a direction that we would take this. Yeah, thanks for the question.
So I know Microsoft doesn't necessarily care about the Xbox One Kinect sensor, but have you looked into using that for your, I guess, experiments and things like that? I mean, I know that technology is supposed to be a lot more impressive as far as articulation and things like that.
Yeah, we got our new Kinect sensors, I think, about 6 weeks before the conference. And so we've been working on this for about a year and a half or 2 years. And so as soon as we get back, that's the next step, is to translate the software over. Our initial look at it is the kind of the resolution and the skeletal tracking does seem to be a whole lot better.
Do you anticipate comparing the, I guess, impact of the 360 sensor versus the Xbox One sensor? I mean, if ultimately you're just trying to get them to move their legs in certain directions, that level of fidelity might not necessarily be necessary, and then that's also a barrier as far as cost for implementation for you or your peers or things like that.
Yeah. So for like the video game intervention, which would be more for the patients, you're exactly right. It's more just kind of, it could be more of a rough estimate as far as movement. But if we look at the screening tool, we want that to be as accurate as possible. So I think with that one, we'll try to get it as accurate as possible, but if cost is an issue. But the good thing, I mean, these, the Kinects are $200. And so there's still there's so much technology in there, and that's why there's, so much potential. We feel it's really unlocked.
Cool. Thank you.
Hi, thank you for your talk. My name is Colleen Clean. I used to actually be an athletic trainer with Stanford's rugby teams here, so appreciate the ACL tears a lot. Question though is are you actually working with anyone outside of your sports medicine department to see how you could take this to maybe an older population that may be more prone to falls or other types of movement conditions that you can work to then strengthen those activities?
Mm-hmm. Yeah, the group that I'm working with in computer engineering and computer science is actually called the Elder Tech group. And so if you kind of Google Elder Tech Missouri, they're doing a lot with fall detection where they mount Kinects up in corners of the room. And there's another PhD student who's working on using the Kinect for a timed up and go test, which is a standard test for fall detection in the elderly. And so as soon as you start messing with the Kinect, like your mind can just go in so many different directions because there's so many possibilities. And with the new Kinect, it has better, you can track people over a wider distance too. And so it's definitely something we're working on.
All right, thank you.
So last question, Aaron. So students, a lot of times in participating in research, they'll come in and they'll fill out some questionnaires, or maybe for sports medicine, maybe you'll move them around a little bit. But you probably have some pretty good stories of them coming in, being excited and playing the video game. So what are some responses or some good stories that you've had in getting the patient or the student's responses in this?
Yeah, I mean, anytime that you have, we see often like teammate, if you have a junior high or high school girl who a teammate has an ACL tear, they're like wanting to do anything they possibly can to do that. And so we actually are going to do, once we kind of get our game a little bit more developed, we're going to do more focus groups with some teenage girls and kind of see kind of their reaction to it and what types of things they like to play, because we really do, for patients and for, to do any preventative exercise, it really needs to be something that they enjoy doing, that they see the purpose behind. If it's something that's just kind of a pointless thing, or, and so that's why we're trying to kind of gamify this and like to add where there's maybe a social interaction and you can share your scores online or see, who on the team can do the most, make it the farthest in Happy Tiger, or anything like that.
All right, great. Well, thank you, Aaron.
Thanks a lot.
And last, to take us home before our break, we have Gonzalo, who's going to tell us everything we need to know about e-health recently.
I will say nothing about that. So I'm last, and that's good because generally Latinos are last, even though in California it's close to 40% of the patients are Latinos. So it's an interesting fact. I would like you to take one of those glow sticks if you can right now, because I'm going to do a little exercise with everybody, because I'm going to ask some questions. So if you can move it out. It's not that you give it to me. My presentation is going to be horrible. So, and also, I just want to tell you that my presentation is being tweeted right now. So you can forget what I say. You do not need to know any Spanglish. And so I would like you to close your eyes for a minute. Just close your eyes. Please follow those instructions. And think of a time in which you felt that you were very successful and effective at using technology in healthcare. Just think for a few seconds. And I need the timer here so that I know how I'm doing, okay? That would be helpful. So I'll give you a minute. Okay. So let me tell you a personal story, as a patient first, so that we're clear that I'm not against technology, obviously. And last January, I was hospitalized, an emergency. An ambulance picked me up at my home. I had a very acute stomach pain. And I'm a celiac patient, so anything that happens to me around my stomach, I take it very seriously. But this time, the pain was excruciating, so I was taken to the hospital, took it into the ambulance, an IV was put on me, and I spent a few hours in the emergency room, and then I was hospitalized because my pressure was very low. I had a very low pressure, and they didn't know what was happening to me. Sometime during that day, they decided to put me in the ICU. And as you know, when you are put in the ICU, it's not a very pleasant experience. You're sort of like hanging on so many things, and with so many things inside you, that quite you do not know where you are. But somehow having a smartphone the whole time next to me was very helpful. I was able to connect via Twitter, via Facebook, and other social media places to connect with the network I know, nurses, doctors, other patients, friends, relatives, here in the United States, abroad, etc. And somehow, those almost 48 hours in the hospital were made bearable because I had a smartphone connected to a Wi-Fi connection in the hospital. And I say this because I think that that was a privilege. And a lot of patients simply do not have the privilege. First, they might not have a smartphone, as we heard yesterday. In fact, I have to rechange my presentation because a lot of what I said yesterday, was said yesterday. And so I thought last night how I will approach this differently. Anyway, and not only a lot of patients do not have smartphones, but a lot of patients, vulnerable, usually people of color, low income, do not have the kind of social network that some of us might have. They do not have the direct access to the knowledge that we might have. So let me ask you a question, and now I want you to use these things. How many of you know how to use Google Docs? Right? How many of you have Netflix? How many of you eat every day at a fast food restaurant? How many of you smoke cigarettes to deal with your anxiety? How many of you have a PCP, a primary care provider? How many of you worry that your kid or your brother or your sister is going to be chewed when they go out in the street? So I ask these questions because often people say, well, all patients are different. That's true. But there are groups of patients that are somehow determined and don't have a choice, and they look a lot alike. And somehow, this is where technology has not been able to make a dent. And what I'm trying to suggest here is that not only technology has not been very helpful in terms of decreasing the continuous growth in inequality in health, but that in some way, one could say that technology and the kinds of tools that we consider part of health information technology somehow actually increase inequality. Because to use those technology, to have access to that technology, you have to have a lot of resources. And if that's what you remember, I'll be very, very happy. The data about health disparities is quite irrefutable. It's quite striking. I came out again to the data that if you compare counties in the United States, longevity is not equal. It's about the difference about 14 years, almost 15 years difference, depending upon the county you live. Longevity, all right? So basically, you died earlier just based on the place you live. And that's true for almost any health indicator. Of course, and you're getting some of the things that I wanted to, of course there are, technology can be extremely helpful. And there's a lot of projects. And I say projects because there's a lot of projects that do not move beyond the piloting or the initial enthusiasm and the proving that the concept works. Because there's a lot of concepts and ideas that do work. For example, Text for Baby. Text for Baby, you're probably all very familiar. It's basically to reach low-income mothers who are going to have babies and who have the babies and use a very basic phone to actually access them. The problem with that is that still we do not have large scales, and we still have not been able to actually know if that kind of technology, even the one that seemed to be working at the pilot level, if it actually makes a dent in terms of health outcomes. Sometimes when I talk about this, I'm asked, well, it is about socioeconomics. The fact is, for instance, for African American women who are educated, highly educated, low birth babies, it's quite striking, the differences between white women and black women. There are aspects in the healthcare system that actually burden even those who somehow have been able to get out of poverty. So let me ask you something. And I want you to think for a few seconds. If you were to design an app, and I sort of give it away here in the Twitter, to actually aid and help people with healthy choices around food. When I ask these questions to IT, technology people, even healthcare people, they go a lot into all kinds of things, but they do not necessarily think about the huge amount of people who actually live in food insecurity. They do not have access to food. An app will not make any difference. And somehow I wonder, when we get excited about an innovation, and it can be technological, it can be a program, what is it that we have at the center? What it would be if at the center we could put the most vulnerable patients, what it would be if at the center we were to think about the minimum common denominator, so to speak. If I were to ask you to design a program to help Palo Alto residents how to exercise more, what would you think? Maybe you would think about Fitbit, right? So help people to self-track, and as they self-track, they get enthusiastic about it, and somehow they might get information about how getting healthier, achieving certain goals, etc., etc. But maybe you're not thinking about those who live in East Palo Alto, one of the places with the highest murder rate in the country, where an app, I'm not so sure it will help, because running around will get you killed. Or maybe not killed, but harassed by the police. So in a way, I think a lot of the technologies have not been necessarily designed around the people that need them the most. As an article in Forbes or in one of these, in a fairly, Wall Street Journal was saying, those who need the best design are not necessarily getting it. Now, let me share with you what I think about, as I ask you to think about for 1 minute, about an innovation where you felt effective and you felt that somehow you were successful. I'll tell you about, I'm a psychotherapist. I'm actually the president of the American Family Therapy Academy. I move myself in different kinds of worlds besides being a public health researcher. I think that there's a lot of opportunities. And I'm going to tell you about a case where I was working with a family of immigrants from Guatemala in Boston. And there were 3 kids. And the 13-year-old girl was being referred by the school because she was having serious behavioral problems. She was, quote, acting out. And of course, if you're an immigrant, you're acting out. It's much worse than if you're white, right? But let's not go there. The first thing I do is I try to set up an appointment. And I try to see the whole family, the 2 parents. In this case, there were 2 parents and the 3 kids. But it was impossible to schedule the session. So, because mom worked 2 jobs, she was a hotel cleaner, and she could not come during the day to a session. So I suggested, and I asked on the phone if she had a cell phone, and she did. And I asked if she had a prepay. There's a lot of people who prepay their phones; they buy minutes. And if she had a ear set, she did, because she actually had a little iPod or some sort of music thing, so she would listen to music while she was cleaning rooms in the hotel. So I asked her if it would be possible for her to connect the headset to her cell phone. So we conducted a family therapy session the first time with her working and the family in my office. And if you think about it, this is a very practical, very concrete way of using technology. What it was interesting is that suggestion, and also at the same time we have in that first session a phone conference call with some of the people from the school so that we will understand what was the perception of the people from the school. And what it was interesting is that as we were thinking and talking about what's happening, in the second session, the 13-year-old girl told me if I would be interested in checking out her Facebook page so that I could understand her extended family. And I say, sure, I'm not going to go to your Facebook. I'm not going to be your friend in Facebook. I'm your psychotherapist. But if you want to bring it, let's open the laptop. Let's look at your Facebook with you. So we did. And as we were looking at some photos that she wanted to show me, we saw that there were some relatives in Guatemala that she had not seen for a long time, and that were very important to her. So at the next session, we actually set up a web conference with, at that time with Skype, now I use HIPAA compliance video conferencing, to connect with a couple of cousins who she really missed, and also an uncle. And they live in a small town in Guatemala. They went to a place where there was a computer, and it was very interesting. We had a session with the mother connected with a cell phone, the rest of the family in Guatemala on a video conferencing call, and the family in my office. So that's, I would say, a technologically appropriate intervention. The use of technology was very empowering to everyone there. And it was not, I learned to use it because, this happened many years ago, because actually it was suggested in some way in the conversation. It was something that actually they brought up and that they found helpful. And I mention it because also at the same time we were listening to the conversation in the morning with Fred Trotter talking about privacy and how, when we were doing the session, there were people walking behind, when you're in a video conference and there's sort of like people sort of behind the, you see sort of, and it was interesting because I was able to ask questions and to find support for this girl. The fact is, a lot of what helped her was to know that there was a huge network that could support her. So the fact is, there's a lot of opportunities for using technology. Right now, I'm thinking on a project where we're trying to figure out how we can develop a network for transnational families, for immigrant families. In Boston, most of the kids who are in the public school system live in families where at least one member is an English language learner. All right? So for whom English is a second language. So one of the things that we have observed is that when kids arrive to the school system, they're enthusiastic. They want to learn. They're really passionate about it. And it takes about 3 months for the kids to actually go down in terms of educational achievement and to start to get sick. Asthma, lactose intolerance, all kinds of allergies, etc. So what could we do to actually engage at the very start with this family and those who are abroad to actually maintain that connection? Because clearly, these kids bring something from abroad that makes them healthy, but it gets lost. We know that acculturation is actually dangerous. I'll stop here. Thank you.
All right. Thanks, Gonzalo. You weren't kidding when you said you were doing a completely different topic from the e-health.
Yeah. I actually didn't know what I was doing in this panel.
You just jumped up here. All right. Extra
I
applause.
have not developed, the epidemic of health disparities, that's a real epidemic. I don't have an app for that. I cannot place a product to actually deal with health disparities. This is a challenge that we have and seriously we need to consider. You think about it. Well, I'm not going to go on.
No, we can now open it up for questions for all of the panelists. So feel free to come up to the floor and ask some broad questions, or I can get started. Gonzalo, one question. So it made me think at UCLA for our Center for Digital Behavior, we're planning next month a hackathon. We're co-creating this hackathon, and it's a global health focus. And so what we want to do is bring in, it's going to be a mix of medical students and engineers and entrepreneurs. And we want to have topics that are focused on global health issues especially so that the medical students who are part of the global health program, when they go abroad, they can use some of these technologies and be able to help the settings they're in. What are some areas that you can think of that would be applicable where within a 24-hour period we're going to give them a problem, and what's a good problem that can be addressed? I'm going to throw your question back at you so that within a 24-hour period they can work with interdisciplinary teams and be able to take that to their international settings where they go.
So in the same way that I tried to flip the classroom, I think we need to try to flip the question. And there's a lot of experience, and I tweet several links to those in Latin America and Africa, where, crowdsourcing, mapping environmental risks, empowering teenagers to find out how to prevent sexual violence, using technology to organize, that's been very successful. So I think that if you do a hackathon, I think that you first need to have all those people in that room to know about those experiences, and maybe to bring those people. I mean, you might not have the resources to fly them in, but maybe there's something to learn from those who are in quite dear situations. I think that sometimes we make the mistake of thinking that those who are the most vulnerable might not have a lot of the answers. And we sort of think, let's figure out a solution for them. And I have a sense that that's very problematic, and it does not generate it. It's sort of like similar to the conversation about patients and providers. Sometimes technology and researchers tend to think of, okay, let's figure out the solution. The solution might be out there. There might be positive deviants out there that we might want to learn something, and we might support.
Do the rest of you have any thoughts on that, just based on the areas that you're working in thinking of something bigger picture for global health? What are some areas where we can, within a short period of time, within a 24-hour period, try to make a dent into some technologies in a global setting?
I think it's interesting what you said, and being in LA, it would be really interesting if you could try to find some immigrants from different parts of the world, who could maybe share and kind of co-design with the medical students at the beginning of that process, and really, because the students might have an idea of is this a problem, and they're like, actually, it's not a problem, or this is the other side of that. So you're in an excellent melting pot where you could do that.
Question.
Thank you for your talk. I was wondering, Gonzalo, if you could talk a little bit more about kind of the problem of privileged innovators in trying to solve these problems for minority communities, kind of like you were saying, with assumptions and ideas of what they need versus what they might actually need.
Right. So this reminds me of a conversation 2 days ago. I went to the Partnering for Health with folks from Lilly and patients, and I raised some of these issues. And one person from Lilly, very nice person. I mean, this is not about good or bad people. I mean, this is, most people in health are trying to do the good thing. So she asked me, what can a company like Lilly do? What pharma could do? And I say, well, every time you sponsor a conference, if the majority of the people who are speaking are white guys, you might not want to sponsor anymore. What about that? In the same way that we want to rate conferences for how many patients you invite, so how about really outreaching and actually paying for people who might look a little bit different, who might bring a different voice? I mean, how many of you here are English language learners? How many of you here come from places where your life might have been in danger? How can you understand the other? And it's not, you cannot have all the experiences, but I think that for cultural humility, I think that there are some things that could be done. Now, your question was what, I lost you, where? Yeah, it was exactly about how to.
Kind of like the problems that privileged people design.
Right, I do think that, I'm a privileged individual myself, and I think that there's a lot of very specific things that could be done that might make others uncomfortable. I think that for me, sometimes I get tired of raising my voice and say, hey, why are you not considering this? Sometimes I participate in Twitter chats about it. The fact is, I cannot not do it, right? And I think that sometimes it would be very helpful for those who are in real privilege, who might never have to worry about some of the things that some of us might have to worry. I mean, every time I open my mouth when the police stop me, I know that I'm going to get ticketed. Because I get nervous and my English kind of really deflates into I don't know what. So it's about how you can really be an ally. The fact is, a lot of the LGBT movement, somehow was able to capture in some way the solidarity of those who are heterosexuals. I think that white folks have still a very high difficulty at being allies. How people in technology, how people in VC and venture can actually support a lot of very interesting things that actually people who look like the 40% of patients in California are going through.
Sorry. So I don't want to turn this whole panel into the social justice thing, but since we're
Yeah.
already here, there's always been a lot of talk about like the token patient at a single conference. Have you
Yep.
found that you are the token minority patient going over?
You said it.
Well, but here's one thing, because I know you have a walking gallery jacket, so you're very prominent
Yeah.
within the overall patient
Yeah.
movement. But
Yeah.
do you find that like people just default to you as a result? It's like, oh, we need to have somebody that
Right.
not white.
So I have the jacket, which is in one of my chairs there. I mean, I can show it to you. And when Regina painted this jacket, she painted my skin darker. And I had a conversation with her about that. And she did it she thought that I was a good advocate for people of color. And I said to her, my kid, particularly my son, he cannot pass as white. I could pass sometimes, really, until I open my mouth, of course. But my son cannot, my daughter cannot. They are seen as whatever, even though they're American citizens, they were born here, the whole thing, where English is not even the second language. So, yes, I am the token, but I'm willing to be the token if needed. But it's exhausting. It's quite exhausting.
Thank you.
So as a behavioral psychologist, a question that always comes to my mind is, with each technology, how do we either make sure it's going to last, it's going to create some lasting change, or what are the issues that we have to focus on to be able to create lasting change? So if you guys can each speak on behalf of your work and address for the technology, is it something that will be lasting change to patients, and what are the issues that we need to think about in terms of how to make it have an impact that's sustainable?
I mean, I guess for our kind of innovation, I mean, lasting change. One is if we can, alert people to their increased risk of ACL tear, to prevent that injury, which can cause lasting harm, as far as arthritis in the future, other problems, and so. I think that really, but the screening is only good if you can develop the good intervention, and so that's going to be a big, part too, and that's what a lot of people have struggled with, is the intervention as far as in any type of injury prevention. So we're going to have to continue to work on that.
Yeah, for us, as far as our technology, we have big dreams about what it can do, the capabilities. I think part of the problem is that we need to start off fairly small and make it more scalable, make it a little bit easier for caregivers and patients to digest, and then start to scale the technology more appropriately as we get buy-in and people become more comfortable with automation of care and having sensors, help dictate turning protocols and things like that. So for us, it's just kind of starting small, adding a technology that will help caregivers do what they're already doing, but doing it better, but then thinking forward how we can actually really start to revolutionize the whole process.
And Thomas, in terms of conversations on Twitter about conferences, what are things that we can think about of how to make the conversations more engaging, or what are different topics
Sure.
that...
Well, first of all, I'd like to applaud the patient movement and involvement. That takes a lot of courage. When we first started to look at the healthcare space, we anticipated on finding conversations that were more industry insider. And we were quite surprised to hear the patient voice, and it's a growing voice. And so I think that that movement, and those of you who are participating in that right now, my hat's off to you. That's a lot of courage, and you've started something very, very strong. Don't stop. And I think that you'll find that others will start to follow. You're leading the way there. Same thing with the conference organizers. There are conferences like this, and there are others here and abroad that are innovators and are inviting this wave of change that's taking place. And I think collaboratively with the representation of all the stakeholders in healthcare is where we can really come up with the new ideas and see change happen.
Gonzalo, you want to give last words?
Thank you.
Well said. All right, well, we're out of time. Thanks, everyone, for joining us. We're going to have a break right now. Let's give a round of applause for all of our panelists.